Hi everyone, this is Neel Raithatha, consultant audiologist and director of WAXscope. I just want to commence by saying a big thank you for everyone. I know many of you have been really concerned about me over the last few weeks, and we've had so many messages at the clinic, phone calls, letters, just asking how I am, and there's been no reason to be concerned. I'm sorry it was a quick disappearing act. It's just that I've been really, really busy focusing on the launch of the WAXscope, and I'm pleased to announce that the WAXscope is to be launched on Friday the 12th of April. And in preparation of that, there's so much stuff behind the scenes that I've had to get done. And one of those things is that I've completely revamped and updated all my training material. And in total, the theoretical aspect is 15 hours, so 2 days of me just talking about earwax and everything that surrounds that. So it's the anatomy and physiology of the outer ear, and then we talked about cerumen and cerumenosis, which is the medical term for earwax impaction. I then discussed all the pathology relating to the ear, so I didn't just focus that on the outer ear, because a lot of the time patients can come into the clinic suspecting cerumenosis. However, they've got other underlying pathologies, and some of these can be really, really serious. So I think in total I've had about 40 pathologies that I've included into the training module. The biggest module is cerumenectomy, so the actual process of removing earwax, and I've covered everything. So a lot of patients attempt to self-clean, so I've covered all that aspect. I've discussed the pseudoscience of hoppy ear candles. I've then gone into real depth about all the different cerumenolytics, all the different earwax types of drops. I then discussed ear irrigation, and I looked at all the literature, all the studies, all the potential complications and studies that have researched complications. We then talked about microsuction, and I kind of discussed everything about how a suction machine works, because I think if you're a specialist, you need to know all these things. Then discussed noise-induced hearing loss, which with microsuction it can be noisy, and I looked at so many different studies and reviewed them. I conducted my own experiments about noise levels with microsuction. So on the back of that, I came up with 15 recommendations for when performing microsuction, and so this is going to be invaluable for specialists that I train and who are enrolled in the course. Then moved onto all the different instrumentation that can be used for earwax removal, and you're just seeing a few of these here. So this is the new Rycorette that I've also developed. Then looked at all the different visualization methods, and this is where the WAXscope really comes, it's relevant. So you've got head loops, which you can examine the inside of the ear with. It's like loops like dentist wears, but they are very limited in terms of magnification. And when you're looking into a narrow orifice in the ear, some of these are really confided in terms of the optics it can provide. We then talked about the ENT operating microscope, then the endoscope, the eye clearscope, which is what many of you are used to. And then I looked at all the pros and cons of all of these devices, and that's what led on to the WAXscope. And just to summarize, so with the head loops, we touched on it. They're portable, they're lightweight, they're inexpensive for specialists to purchase. However, it gives you really bad body posture because you've got a head forwards position all the time. The magnification is really, really limited, and for that reason, you get really kind of a shallow, really shallow depth perception there. ENT microscope, in terms of magnification, it's out there by itself, so it's got a huge magnification. However, with an ENT microscope, they're not portable, they are very, very expensive, and many people struggle to view through binoculars because you get optics from each eye, and it's the optics from each eye which then gives you the binocular depth perception, which most head loops don't provide you. And in fact, with most head loops, not all but most, you're looking into the ear with generally one eye, because both eyes just physically can't look into a small space like the ear with the head loops. But the microscope overcomes that issue because it converges your eyes together, it decreases your interpupillary distance, so it's almost turning into Cyclops, but not exactly like Cyclops, because if it was both eyes converged, then that would be monocular vision, a bit like head loops. But it brings it together to about 12 millimeters even, which then enables you to look very deep in the ear with both eyes, and that's depth perception by binocular vision. But many people struggle, they get double vision with an ENT microscope, and you have to constantly reposition an ENT microscope, because just like the WAXscope and the head loops, the focus is completely different to an endoscope, because with all these other contraptions, all the visualization methods, other than an endoscope, the lens is outside of the ear. So you've got no choice but to adjust focus. And with an ENT microscope, it's very, very difficult to do that. Once you're used to it, it's not, but it's constant repositioning. If the patient moves slightly, or you're then removing a bit of wax further in the ear, you're having to kind of move a big optical unit forwards and backwards constantly, and then adjust your body position as well. With the endoscope, there's no rivaling the field of view. There's no getting around that. The an endoscope for me is the best method of removing earwax. However, unfortunately, a lot of people really, really struggle to use an endoscope. They struggle to hold it, manipulate it into the ear, because our ears are not straight cylindrical tubes. They're bendy, narrow, twisty, and we have to straighten the ear to gain access a lot of the time so you can put the instrument in. So an endoscope, a lot of people struggle to do that because there's no speculum. So a speculum is what you're seeing on screen at the moment. Whenever an audiologist or doctor or ENT trains to look in the ear, we all use a speculum. This is the view that we get. So speculum helps to straighten and dilate the ear. So in the absence of that, with an endoscope, you're having to do that yourself using the side of the endoscope. So it requires a lot of bilateral integration between both hands, and people really, really struggle to do that. And the way you hold an endoscope, the grip, people can find it quite heavy. So here comes the WAXscope. So the WAXscope, in terms of an endoscope, is much easier to hold, and it's got a speculum attachment, as you can see. In comparison to a head loops, the magnification's on a different league. In fact, the magnification of the WAXscope you can put on par with an ENT microscope. Unlike an ENT microscope, the WAXscope is portable, it's significantly cheaper. In terms of constant readjustments, they're so much easier to make. It's just a swipe on the screen. You adjust the focus on the screen. We've even got a double tap autofocus. So we've overcome that. If the patient moves slightly, it's not an issue because the speculum is already there, and you've already got it fully inserted. You're just going to make adjustments on the screen. The kind of with an endoscope and the WAXscope in particular, you get depth perception, but you don't get it by binocular vision. So it's a different way because both eyes are looking at a screen here. So unlike head loops, with some head loops where you're only looking with one eye, with a WAXscope and the endoscope, you are looking at the screen with both eyes. And obviously, when you look at something with both eyes, you get better acuity, better clarity. But the depth perception with the endoscope and WAXscope is not via binocular vision, because both eyes are looking at a 2D screen. Instead, you're using monocular. So yes, you can get depth perception with monocular vision. In the presentation I've given, I've even done a whole kind of topic on that, because there's a lot of people who are under the impression you cannot get depth perception using an endoscope or WAXscope. Now, if that was the case, why is keyhole surgery being performed in an endoscope? Why are ENT surgeons performing middle ear endoscopic ear surgery? That's all 2D vision, that's monocular vision per se. And it's just different cues. And you can see, I've been removing wax off the eardrum with an endoscope for almost a decade now. And similarly with the WAXscope, I'm able to do that really, really comfortably. And another advantage of the WAXscope and the endoscope is that you've got the ability to record. So these are all the reasons why we've developed the WAXscope. Now, I'm going to come back to this video. You just saw me clear all this wax out. It's a patient had a very, very narrow ear canal. So we're using the smaller speculum to straighten and dilate it. You can see all the blood capillaries, vessels there on the eardrum. That view is just amazing. Now, at the bottom, this patient's got a bit of residual wax, what looked like wax, but it isn't. Underlying this, they've got very likely an early stage canal cholesteatoma, probably a stage 1 or 2. So this is a canal epithelial hyperplasia. So here there's a buildup of dead skin. And I'm going to zoom in a minute. You're going to see the view. There's a little cyst beyond that as well. So I'm going to go in, you're going to stretch and dilate the ear canal. And there's an ulceration present here of the skin. So there's a bit of skin missing. And you've now got deposits of keratin. So keratin is the protein that's found in the outer layer of dead skin, the stratum corneum. And it's infiltrated this. And I am actually going to resort to the endoscope However, I actually found it easier doing this with the WAXscope because I just had more stability. So there's me zooming in, and that's all keratin, that light, shiny, glossy patch of skin. That's keratin, and it's just embedded. And we've referred this patient on to ENT, and you can maybe see the outline of the ulceration. And I think this is actually going really, I think canal cholesteatomas, that we call it a rare condition, but I think they are actually underdiagnosed because quite often they're lurking underneath some wax or some skin on the ear canal floor. And I've given some examples in my training course of that actually. So we're just trying to get this out. You can see I've moved quite a bit there. Now, this patient was getting a bit dizzy a bit later on, so we had to stop. They had a bit of the chloric effect. You can see I've already got loads out there. And now, the reason why I found the WAXscope a bit easier than the endoscope, because you may have just noticed it there, just as we enter the ear canal, this patient's ear canal's got a little bump that goes up. And with the endoscope, I just found it difficult to rest it against that to stabilise the views. But here, the speculum attachment, I was able to do that. So underneath this keratin is likely to be exposed bone. And this is the endoscopic view. So you can see there's no speculum there. But it was just a bit tricky just to get the correct alignment here. So again, the WAXscope is not a substitute for the endoscope. It's an alternative, but also complementary. Quite often now I'm using the WAXscope for certain procedures over an endoscope. I've just become so comfortable with the WAXscope, especially with children. The WAXscope really stabilizes it. So you can see there's a little cyst forming here underneath that stratum corneum, so that could be another piece of canal cholesteatomas. In these cases, they need to be referred to ENT. They need to undergo a CT scan. I think they're not quite dizzy yet. So I'm just trying to, it was a bit shiny, so I'm just adjusting the optics slightly there just to get the optimal view. I'm just having a good examination. I think I am good. There we are. I'm just going to just reposition myself. You can see that ridge I was talking about. It was very difficult to rest it, so I'm having to enter with the instrument first here. And you can see that ridge again at the bottom. This just wasn't enough. It was just the angle of that after ridge, but you can see I've just got a bit more keratin. I'm happy with that. There's no active discharge. This may even be early stages benign osteonecrosis, but I do think it's a canal cholesteatoma. So we don't know how much of this keratin, how much has it infiltrated the underlay of skin. In some cases, if you dissect the skin and you visualize underneath the floor of the ear canal, this is extensive, it's all over the place. The ulceration, and you'll have exposed bone, which is separating, so sequestration of the bone. Because this skin, it releases proteolytic enzymes, lysosomal enzymes, which are digestive enzymes, and they start chewing away at the flesh, the underlying bone. Also, there'll be some bacteria involved here because in the center of the cholesteatoma, you'll get a bit of keratinous tissue, and debris and bacteria will feed on that. So I'm just trying to pull this out. And remember the patient, we've got to be aware of the patient as well, because although they were really, really fine and they were saying they were comfortable, you can quite easily, this is on the bony part of the ear canal, it can cause a lot of discomfort here. So I'm just going to kind of clean a little bit more now. I think we're done. And this patient's already arranged appointment to see a private ENT. The waiting list at the moment is really, really long. See the adjacent skin is a bit inflamed, but yeah, I'm happy with that. I left that other piece of kind of skin just in front because the patient did get a bit dizzy, but I managed to clear most of that debris. But you just don't know how much there is there because that's a hidden ulceration. Is I can just see a bit more keratin there just at the ridge. Well, I hope you enjoyed that video, guys, and take care, keep well, and speak soon. Bye.